Good morning, everybody, and thank you for coming to this rather early talk. I'm going to give you a flavour of the surgical journey that our unit has been on and are still on, transitioning from a largely VATS unit for our lung cancer practice to a largely robotic approach. For those of you who don't know who I am and who we are, Guy's Hospital are one of the UK's larger lung cancer surgical centres, currently about 650 anatomic resections a year. And we were early adopters by UK standards, at least, of VATS lobectomy. I came back fully trained from New York in VATS lobectomy when I started as a consultant in 2007, and we've been doing it since then. And we were doing a good volume, 400 cases a year of multi-portal VATS lobectomy, and we were pretty happy with it. We started our robotic program at a fairly low level, just one day every couple of weeks, wrestled from the urologists in about 2016. And we've just built progressively from there into now what's a relatively high volume robotic practice, 2 to 3 cases a day, 5 days a week, sometimes 6 days a week. Embedded in a hospital that has invested fairly heavily clinically and financially in robotics. So we have 5 Da Vinci systems at the moment across multiple specialties. We have a structured fellowship, which is popular with SETS sponsored trainees as well as international trainees, and are on the way to replacing our VATS practice with a robotics practice, although we've still got a way to do yet. A way to go before we are fully there. I'm aware that some of you will have only a little idea about how thoracic robotics works, and this is just a short 2-minute video that we made in conjunction with the College of Surgeons to help educate people who are robot naive as to what it's all about. So I'll just play this for a couple of minutes, just as a brief technical introduction to how the kit works and how the surgeon interfaces with it all, before we move on to what the reasons for going down this route might be.
This video depicts the functionality of one of the current robotic surgery machine systems seen in hospitals today. It will portray the operation of the machine from setup to intraoperative performance. To begin machine setup, the patient cart is driven from the helm until the laser crosshairs are positioned within 5 centimeters of the initial endoscopic port. Now that the crosshairs are positioned, the first endoscope arm can be docked to the patient. Once the arm is docked to the cannula, the operator uses the instrument clutch to point the initial clutch to the target anatomy. During targeting, the system positions the boom over the initial endoscopic port, orienting it to maximize range of motion. In turn, the boom may pivot, rotate, and adjust its vertical position. After the camera arm has been docked to the patient, the other instrument arms may be docked as well. This completes the system setup. The machine is operated by 2 surgeons seated at separate surgical consoles, from which they are able to control the movements of the instrument arms remotely. Instrument repositioning is directed by the surgeon at the console by pressing and holding the master clutch pedal, disconnecting them from the instruments, and enabling the surgeon to position the instruments comfortably and regain working space at the console. With the machine and the surgeons in place, the system is now ready to operate.
So that should give you a bit of a flavour as to what it's all about, if you haven't seen the system in action before. So to get back to our journey, why did we start robotics? Because we all know that surgery is pretty good. And I think it was a mixture of reasons, some admirably scientific and some shamelessly self-promoting. I was very curious about what it might be. I'd heard about it, and I wanted to find out what it was all about. And I was becoming aware of the limitations of VATS in complex cases. Yes, you can do a complete lymphadenectomy. Yes, you can do a sleeve VATS. You can do a post-radiotherapy case. But these are difficult things to do and dangerous things to do, and felt like it was pushing the limits of a technique beyond what was perhaps sensible. And in London, there is competition between units to an extent. And I had and we didn't want to lose out on that front. And I had a strong intuition, which has of course grown stronger over the years, that this was going to be the future direction that minimally invasive cancer surgery was heading in. And I thought it looked fun. People often ask me the actually rather difficult question of what is it that makes robotics better than VATS and better than open? And I think that question can be usefully broken down into the most important part, which is how is it better for the patient? But also we can look at why is it better for the surgeon and why might it be better for your hospital as well. So to take the first of those, why is it better for the patient? And what does better for the patient mean? It would mean fewer complications, a quicker recovery, and also a better cancer treatment. And I think there is growing evidence that robotic surgery offers at least the potential for all of those improvements. Although, of course, the clinical data are still somewhat lacking, and we are all very aware of that. And how do those potential advantages for the patient, in other words, for the technical conduct of the operation, come about? And I think there is no one single killer advantage of robotic surgery over conventional straight stick VATS surgery. It's a collection of marginal gains which adds up to a clinically worthwhile improvement, but no one of them are individually enough to hang your hat on, perhaps. The most striking thing for people who engage with this technology, first of all, is the amazing visual awareness of the surgical field. Even compared with a high definition VATS stack or a 3D open console VATS stack, putting your face into the viewer when the camera's inside a patient is just a totally different way of appreciating and being immersed in the surgical field, and gets you off to a very good start in terms of being able to carry out the surgery better. We tend to operate with the tissue much closer to the camera, so with a much more magnified view of the tissue. So your appreciation of the tissue planes around lymph nodes and things is it's not just better, it's of a different character to the tissue visualization that you can get otherwise. And that, combined with the robotic control system, allows a precision of dissection that is just different and better from anything that you can do open in VATS. And that must lead to reduced micro-tissue trauma, and certainly does lead to a reduced inflammatory response to surgery as judged by cytokine release. All of these are secondary measures of patient benefit, but are still very much worth taking into account. Most of this comes about by wrists. The simple but extremely powerful fact that the robotic instruments are wristed rather than straight is really where a great deal of the benefit lies. And being able to retract the tissue in exactly the direction you want and to cut the tissue in exactly the plane that you want is really, I think, the heart of why this is better. And it's interesting and different to have direct control over all aspects of the operation. If you're carrying out a VATS lobectomy, you typically would delegate retraction and camera positioning to an assistant who may be very good or may not always be very good. But the fact that the primary surgeon has direct control over all of these ancillary aspects of the operation is, I think, actually a strong benefit. It takes some getting used to. There's a lot more things to think about while you're doing the operation if you're going to do it optimally, but there is the potential to optimize a number of aspects of the operation that are usually delegated to somebody else. I think intraoperative imaging is going to be a strong thread for cancer surgery over the next 10 years or so. And the robotic systems are already ahead of the game by and large in terms of offering built-in near-infrared imaging, which is very useful for assessing vascularity phrenic nerve placement, that sort of thing. It's straightforward to plug in an in-field ultrasound probe into the back of the robot, and you then get an ultrasound image overlaid on top of your surgical field to find nodules within the lung. These are just the rudimentary beginnings of intraoperative imaging enhancements, which I think are likely to be built on over the next few years. And the much vaunted lower port trauma, lower damage to the intercostal nerve. The way the robotic ports articulate is controlled in a way that means they pivot about a particular point, and there is at least the potential for less intercostal nerve trauma and periosteal trauma, and potentially less pain. This is something that certainly warrants further examination, but remains in the considerable group of potential but unproven robotic advantages. What this adds up to in clinical practice is, I think, an ability to carry out minimally invasive surgery on a greater proportion of your cancer cases. I found in my practice, and as I said, I'd done many hundreds of VATS lobectomies before I started robotics, and my proportion of minimally invasive operations went from about 70% to about 90% during the adoption of robotics. The difference being largely the more complex cases that I might have chosen to undertake open or might have converted, being more comfortably undertaken by a straightforward and minimally invasive approach. So that's one concrete example of benefit. Another is complications. We all know that serious complications and death are actually quite rare these days, and so proving a reduction is quite difficult. And what we don't have for sure is level 1 evidence of this, but what we do have is initially the usual large US healthcare databases showing VATS versus robotic. There is a reduction in complication rates, mostly from papers that Dano from California has published. We are looking at our data set at Guy's over the last couple of years with matched cohorts of VATS versus robotic patients. And again, we are seeing a similar, about a 25 to 30% reduction in significant complication rates. I should add that most robotic surgical case series are heavily selected, with people cherry picking the sweet cases for their robotic practice. Our case series showing this reduced complication rate is non-selected in the last year or a year and a half. I've had open access to the robot, and so I've been doing everything robotically, whereas before I was doing most of it VATS. So this is an unselected VATS versus robotic case series showing with reasonable numbers, as you can see, showing some early evidence that we may be going to see a reduction in complication rates. The other thing that's demonstrated, which is worth having, is increased nodal upstaging, particularly the critical upstaging from N0 to N1, which obviously impacts on postoperative chemotherapy. And we are seeing, again, from the Guy's data set, an increase of 7% with VATS, with a kind of, real world approach to lymph node sampling and dissection, increased to 21% with our robotic data. So that's, again, something that is going to translate into better overall cancer treatment. And we're seeing lower conversion rates. The conversion rate at Guy's was always quite low, but the published conversion rates from the US healthcare databases suggest that robotics has a lower conversion rate and a lower major vascular injury rate compared with VATS. Possibly quicker recovery and less pain. This isn't something I emphasize a lot. I think VATS is so good at this, embedded in an enhanced recovery program, that it's going to be difficult to make major inroads into these metrics, but there is at least a possibility for these things being better. I think an important point to emphasize is, and again, this is a matter of opinion rather than data for now, is that robotic surgery, the enhanced capabilities may not make a dramatic difference for your easy lobectomy for stage 1 lung cancer, but is clearly a better platform for the more complex minimally invasive cancer resections, which I think are the direction of travel of lung cancer surgery. I think we all expect to be doing more segmentectomy in the future. Clearly, operating in the context of preoperative immunotherapy is something that's coming as well. And I don't know if you have much experience of that. I only have a moderate experience of it, but it's pretty tough, particularly if it's more than a month or so after the immunotherapy. the hilum is a lot more fibrotic and sticky, and these cases are pretty technically challenging. And I think robotics is going to come into its own in that type of environment. And I think we all expect and hope that the role of surgery in more locally advanced and even stage 4 disease as salvage consolidation therapy is likely to expand in the future. And again, for these more challenging operations where a straightforward VATS approach might be knocking up against its technical limits, I think a robotic platform is going to offer the enhanced capabilities that we will need in the future. People at this stage often say, well, I don't believe you until you show me, a multi-unit randomized controlled trial of VATS versus robotics. I'm not sure that trial is ever going to happen or be sufficiently powered to show a benefit. My view is that this change is going to happen for a number of soft cultural reasons, supported perhaps by registry data rather than randomized controlled trial data. I think waiting before you shift over to robotics for a large-scale randomized controlled trial is going to mean you end up being left behind. I obviously appreciate the value of level 1 evidence, but I think sometimes it isn't going to happen. So that's what I've got to say about benefits for the patient. Benefits for the surgeon. So I think that what I found most of all, this is a very enjoyable way to do the operation, and I have a strong intuition that I'm doing a better operation. And that's a very satisfying thing to do. We're all constantly seeking to improve the way we do things, and this just feels like a better way to do it. It sounds like a slightly lame thing to say, but it's a very powerful intuition, and very few people step back from robotic surgery once they've started, and I think that's largely what drives that. Increasingly, patients and referrers are seeking out robotic thoracic surgery over other approaches. It's only beginning to happen, and we know that UK patients by and large go where they're told, but increasingly I'm beginning to see patients who are prepared to travel for what they perceive as being a better treatment. It is probably a better way to train registrars. I've trained a load of registrars in VATS lobectomies and a smaller number of registrars, about 4 in robotic lobectomy. So it's perhaps too early to say definitively, but my impression is that a dual console robotic setup is a more efficient and probably safer training platform than VATS lobectomy, and people seem to be able to get up to speed really quite quickly, as I say, particularly with the dual console setup. I think all of us are worried about being left behind, and I think the days when robotic surgery was something that was rather a niche activity done by a few people in dark corners, being ignored by the rest of us, are now long gone. The majority of UK thoracic centres are now either have a robotic program or are campaigning hard to get one. And something that I think isn't talked about enough is the physical damage that surgery does to surgeons. I'm beginning to get into the age group where this is entirely relevant to me. And certainly I was finding after 3 VATS lobectomies in a day, usually assisting my registrar, that my back hurt and my knees hurt because they were twisted at weird angles while I leant across the patient. And I wasn't sure whether this was going to be sustainable for further decades. And if you look into it, there's a substantial literature on surgeon musculoskeletal damage as a consequence of their operative practice. Not surprisingly, it's worst in bariatric surgeons, and really quite a shocking proportion of them, over 40, experience moderate to severe musculoskeletal pain as a consequence of operating, and a quarter of them have had to curtail their surgical load as a consequence of that pain. So there is a real problem with senior surgeons who would otherwise have a lot to offer having to cut back their operative practice a lot. And robotic surgery makes this go away. You comfortably sit at the console in an ergonomically very comfortable position with your arms supported and your neck supported. And at the end of a day in the robotic operating room, you feel fresh and relaxed, and rather than beaten up and exhausted. And that's got to be a good thing for individual surgeons, but also for society. Surgeons are, senior surgeons are expensive creatures to have trained, and if you've got to throw them on the rubbish heap because they've got neck pain and back pain and can't stand up for a 10-hour operating day anymore, then that's a loss for everybody. And this is a problem that just goes away with robotic surgery. And there are benefits for your team and for your hospital as well. Firstly, staff recruitment and retention. Robotics is popular at the moment, rightly or wrongly. Everybody wants to work in a robotic program. The last few senior registrars we've trained have turned down jobs or not applied for jobs simply because their unit involved didn't have a healthy robotic program. We find it easier to recruit scrub staff. Obviously, registrars are all very clear that this is the way they want to go. If you run a robotic training program, then registrars will be queuing up at your door. So staff recruitment and retention is a lot better if you have a robotic program. We've already discussed that you can attract more referrals and build a practice better. There is prestige to institutions attached with robotic surgery, and all chief executives want to run a high prestige hospital. And there is the possibility to reduce your costs in many areas of the hospital. Robotic surgery is expensive, and I think this remains and will remain the most significant block to starting robotic programs and to expanding robotic programs. There's the cost of buying the robot, the service contracts, and the disposables as well, all of which mean the upfront cost of a robotic lobectomy is probably something in the order of £1,500 to £1,700 more than a VATS lobectomy. Obviously, that depends on how expensive your VATS lobectomy is. If you use a lot of advanced energy instruments and expensive instrumentation generally, then the difference may well be a lot less. Some of the robotic costs are less than people expect. Robotic stapling, for instance, is no more expensive than conventional stapling, but nevertheless, there clearly are increased upfront costs. But some of those costs can be offset by reduced downstream secondary costs. We've talked about reduced complications, and complications mean prolonged stay, but particularly prolonged ITU stay and involvement of cardiology. And all of those aspects of care are very expensive. In addition, there is evidence of reduced readmission rate following robotic surgery compared with VATS surgery. Readmissions are expensive for the health service. They're expensive for your individual trusts as well. And so there are real downstream cost savings that can be used to offset the costs of robotic surgery. Not surprisingly, Intuitive are all over this and have a very nice healthcare economic analysis package, which will allow you to try and perform an analysis like this, but tailored to your individual situation. So you can plug in, of course, all of the additional robotic costs, but you can plug in data from your own practice or from UK practice. And if you don't have that data, you can pre-populate it with data from international published case series. As regards, your complication rates and conversion rates and readmissions and length of stay. The more of your own data you have, the more reliable and robust this analysis will be. But what it allows you to show is that a great deal of the increased upfront cost can be offset. You haven't got to save very many patients going to ITU for 2 weeks, with AF and pneumonia. To pay for an awful lot of robotic instruments. And so you only need evidence of a modest reduction in complications to offset a lot of the financial hardship that is associated with robotic surgery. That's all well and good, but there is no denying that robotic surgery is still more expensive. And if the game you are asked to play is to prove that robotic surgery is cost neutral compared with your current practice, that probably isn't going to ever get you anywhere. I think it's important to accept that robotic surgery is a more expensive way of doing things, and be in an environment where that is accepted, and you're going to do it anyway. As I say, I think there is an increasing feeling of inevitability about all of this, whatever your feelings about the current clinical data set and the costs. This is clearly a direction that we are going in, and it's not just us. Colorectal are heavily heading in this direction. Around the world, colorectal and gynecology are nearly as big, if not bigger, than urology. So the perception that this is just something for the prostate chaps is really no longer the case. certainly around the developed world, it's becoming standard of care for colorectal surgery, for gynae oncology, increasingly for thoracic, and increasingly for upper GI surgery. It's heavily, it's gaining ground in hepatobiliary surgery. So really, for all of us doing solid organ cancer surgery, this is the direction we're going in. There are multiple new platforms coming out, which wouldn't be the case if all of the medical device companies didn't feel strongly that this was the way things are going. So I think we are now looking at a situation where conventional straight stick minimally invasive surgery, other than for pleural biopsies and the very low complexity end of things, is inevitably going to be replaced by a combination of robotic platforms. The question isn't when are you going to. The question is not going to be are you going to change to robotics. The question really is when are you going to change to robotics? Are you going to do it now? Are you going to wait and risk being left behind, but see what the market offers next year or the year afterwards? These are all considerations, but continuing to do VATS and open surgery is really no longer a medium-term option for any of us. There are a number of other commonly voiced, but I think spurious objections to Da Vinci robotics. There's the concern that it's slower. And indeed, with earlier platforms, earlier versions of the technology, which were much more cumbersome and less user-friendly, particularly for a multi-quadrant thoracic operation, it was slower. But it doesn't have to be slower. We do 3 major resections in our standard operating list with our standard team, and we're done by 4:30. It's taken us some effort to get there, both in terms of the team turnarounds and in terms of the technical surgery as well, but it's entirely achievable to do. Whatever you're doing currently on your operation lists conventionally can be done robotically in the same time. There is a sensible perception that it may be dangerous, and the feeling of a major PA injury when you're sat at the console in the corner of the room, you're not even wearing sterile gown and gloves, it is potentially a more dangerous situation. And you need to know how to handle it as an individual surgeon and as a team. And when I started off, I did not know how to handle it and got into an extremely nasty situation. However, on reflection, we developed a relatively straightforward process to deal with this, which we now share with any other teams that come to us for training. And we've had a small number of major vascular injuries since over the last 2 or 3 years, and none of them have resulted in more than about 200 or 300 mils blood loss, and there's never been any drama. We're able to control the bleeding with the robot and open, and everything is fine. So yes, it's important to think about it and not dismiss this concern, but it's ultimately not a reason to proceed. Some people complain that it's a lot of incisions compared with the uniportal VATS, and that is true. But my view is that a number of incisions is not a good measure of surgical toxicity. And uniportal VATS is a great technique for relatively straightforward lobectomies, but I don't think has the sophistication to deal with the range of complex requirements that the future of lung cancer surgery is likely to require. What's wrong with open surgery? Well, open surgery is great, and when you need to do it open, you need to do it open, and the patients often do very well. But across the board, robotic surgery is safer and less painful and probably less expensive than open surgery overall. It's important to carry this out in a multi-specialty environment if possible. There's a lot of costs and complexity that can be shared. The scrub staff, I'd far rather do this type of surgery with scrub staff who know about robotic surgery, even if it's through urology, rather than thoracic staff who don't know about robotic surgery. So a shared pool of scrub staff with gynecology and urology makes operating room team skill easy to maintain. You'll need a bedside assistant, and that is again something that's best shared across multiple teams. You'll need complex instrument sterilizing processes, and these are all much better done at scale. So, and the one thing that's very clear with robotic platforms is you need to maximize use of them if you're going to get anywhere near being cost effective. And that means using it every morning, every afternoon, Monday to Friday, and weekends if you can. And that's much easier to achieve across multiple specialties. And most people will start with one robot, and having multiple specialties involved means that your business case, which you'll be very rapidly moving on to for robotic expansion, is much more powerful. If you go to the chief executive of your hospital with all of the clinical leads from your major cancer surgery divisions all demanding more robots, it's very difficult for them to ignore it. Whereas if it's just a thoracic surgeon making a fuss, you can easily be sidelined. So multi-specialty is good across the board for robotics. It's a few tips for people who are getting closer to starting. It's important to make this a team event. It's very easy to focus entirely on the operating surgeons and their experience and their training. But actually, for this to succeed, you need the whole team to be involved. And that doesn't just mean the operating room team. It means the managers, the finance guys, the governance people. Everybody needs to be on board with this, not just so that they don't obstruct your way in advance of starting, not just so that your operating room experience is as smooth and as safe as possible, but also because when you stumble and you do cause a PA injury or have a major complication, it means people are still on your side and they won't be looking to shoot you down straight away. This is a new way of doing things, and it's important that you explore with your hospital what the governance requirements are. Often it will require specific patient information leaflets, approval from your hospital's new procedure committee. It may well require a new consent process. You need to approach all of this and get it signed off before you start. And of course, put an audit database in place. I'm not the world's greatest fan of audit, but you need clinical data if you're going to demonstrate internally and to a wider audience why you're doing this and what the benefits might be. A currently unique feature of the robotic learning curve for consultants is that the Intuitive Surgical, the robotic company, will provide you with a mentor to help you along your learning curve, which is enormously helpful. But it's important that you get somebody. It's unusual as a consultant to go back to being taught by somebody else. It's important you work with somebody who you think you can develop that relationship with. Ideally, somebody with a consistent presence, either remote or face-to-face, and also somebody who does the operation the way you want to do it. There are a number of ways to skin this particular cat, as ever, and there's no point in learning how to do the operation from somebody who does it a way that you don't aspire to do it. So shop around and find out who does the operation you want, who does the operation in a way that you want to learn how to do it, and ask them to work with you to get through your learning curve as quickly as possible. And the learning curve is painful and it can be frustrating, and to go from being very good at something to being rather less good at it for several months is a painful thing. The best way to get through it is to get your head down and just keep doing it as often and as much as you can with as much help as you can get, rather than lapsing back into non-robotic practice at the first sign of difficulties. But it is tough. Obviously, you need a stable team when you start. The bedside assistant role is critical, and you need to give thought to who's going to do that. Most programs start with either a second consultant or a registrar at the bedside, which is fine, but you don't want to turn a lobectomy into a 2-consultant operation in anything other than the short term, because that's hugely expensive. And registrars will firstly come and go, and you'll be constantly retraining a bedside assistant in how to handle that part of the robot. And ultimately, you quite quickly want to move on towards training the registrars how to do the operation from the console, rather than being an assistant at the bedside. And so the only really sensible longer-term approach is to have some form of advanced nursing role. And we think a surgical care practitioner is the best person for this. So our cardiac colleagues have long been very reliant on a pool of surgical care practitioners to deliver their surgery, and robotic surgery brings that reality to thoracic surgeons as well. And that's something that we can embrace, because not only can they contribute to the operating room, but as in cardiac surgery, they can help on the ward, they can help in clinics. So it's a reason to expand the reason to expand the surgical care practitioner role more widely within thoracic surgery as well. You need to start off with easy cases. I've already discussed you need to have an explicit plan for what you do when you make a hole in the pulmonary artery. You need to know what to do as a surgeon, but your team needs to know what you expect them to do as well, so there's no panic. And again, to come back to the team aspect of it, you need to make sure everybody understands that when it goes well, this is a whole team achievement. It's not just on the operating surgeon. And make this a really positive feel for everybody involved. As I've said, the learning curve is slow and longer than anybody would like. I think it's perhaps as much as 50 cases before you're really firing on all cylinders. Certainly it's 25 cases before you remotely feel like you've got the hang of it enough to be anything like an expert. And it's painful to get worse at something before you get better at it. You have to very much have your eyes on the horizon and believe that where you're heading, i.e. being an expert robotic surgeon, is worth the pain of getting there and is achievable. You don't want to train the whole department at once, partly because you want to intensify the experience on one or two surgeons, but also because you will detract majorly from your registrar training during this process. You'll be funneling the straightforward lobectomies towards your consultants learning robotics and away from your registrars, and that will hurt your unit's training program, at least in the short term, and you want to find a way to minimize this. You want to go off during your learning curve and watch other surgeons around the UK and hopefully soon around Europe who do this well and have significant expertise. Watching somebody do an operation before you've ever done it is interesting. Watching somebody get past the minor obstacles that you've run into after you've done 10 or 20 or 50 of these is much more illuminating. Intuitive have done a great job at setting up a network of surgeons who are happy to teach. And it makes the learning curve vastly better and vastly different from any other surgical learning experience you will have been through, particularly as a consultant. So to come back to the beginning again, the important question for everybody is it better than VATS? And I think the answer is, for more complex resections, mediastinal resection, more complex resections, segmentectomy, obviously, post-induction resections, I think the answer is a definitive yes. Honourable mention goes to anterior mediastinal masses in particular. I don't really like VATS thymectomy. I find the dissection up into the neck and around the innominate vein always a bit cramped and really quite compromised. And robotic mediastinal dissection is dramatically different, mostly because of the wrists and the ability to really retract the horns of the thymus and retract the innominate vein very precisely and dissect around it in a way that is both safe and much more straightforward. So thymectomy is a dramatic early win. Is it better than whatever your chosen VATS technique is for an easy stage 1 lobectomy? I think it's going to be difficult to find a measurable benefit in low-risk patients having straightforward surgery. Obviously, it can be difficult to spot the straightforward operations, and we all know that you can start off what you think is going to be an easy VATS lobectomy and find out actually there are lots of adhesions and the hilum is frozen. And for those cases, you'd be very glad you were doing it robotically rather than VATS. For your unit generally to be able to increase the proportion of minimally invasive surgery, particularly more complex minimally invasive surgery, I think is a very clear win. And to come back to perhaps the most definitive point, manual straight stick minimally invasive complex surgery is just going to disappear. And so at some point we are all going to have to grapple with, probably a variety of platforms, but for now, very much with the intuitive platforms. And I think that's something that we should all welcome and enjoy. So that is the end of my talk. I will be available to answer live questions from here onwards. Thank you. So, hi everybody. Thank you very much for tuning in and listening to that. We have had a number of questions through during the talk, and obviously, please feel free to send through any further questions. I'll get going on the questions we've been asked so far. The first question that came through is that some surgeons feel it's useful to have an assistant with a metal sucker to keep the field dry during operations. So that raises the wider question of, is it useful to have an assistant port in addition to all of the robotic ports during robotic operation? And I think it's a matter of preference. I usually do. Partly because I have a very good bedside assistant who's able to be very active and helpful, partly because I feel it adds a level of safety, particularly with a trainee during the operation. If you suddenly have bleeding and you need to evacuate blood from the field quickly, then having immediate suction is helpful, but it's not required. If you do use it, you can use pretty much any regular suction device that you'd want to use. We use a long striker sucker. There are very nice robotic articulated suckers that you can use through the robotic arms as well. They add a couple of €100 cost, but I tend to save them for situations where there's unexpected low-level bleeding, just to keep things nice and dry. It is a truth of robotic surgery that you need to keep the field completely dry because you're so dependent on vision, and so suction and swab changes to keep the field dry are quite a big part of it. The next question is a reasonable question saying, so with the limited level of data supporting robotics over VATS, how did you get the hospital to start with robotics and who was involved? And I think that's a challenge that lots of units are facing at the moment. And the clinical data set isn't like to change dramatically. There are two small randomized controlled trials of VATS versus robotics, one in Italy and one in Canada, that will be reporting soon, but they're pretty small. They struggled with recruitment, and it's unlikely that they're going to show a definitive difference either way. I think the first thing to say is you have to be in a hospital that wants to do this. My hospital had a very clear vision that they wanted to be a large multi-specialty, multi-robot centre of excellence, and they were prepared to invest in that. In addition, our commissioners, and I know the commissioning landscape is changing and clinical commissioning groups are being disbanded in favour of new, larger organisations, which may be an advantage or a disadvantage, but it's worth speaking to whatever level of specialty commissioners you're dealing with and asking if they will provide additional tariff support. There are national robotic tariffs for urology operations, and we negotiated a local enhanced tariff to offset a lot of the additional cost for thoracic and now gynecology operations. So I think it's definitely worth a conversation with your commissioners to see if they will share the cost with the hospital of this more expensive treatment. You need to be in a financially supportive environment. As I said during my talk, if you are being required to demonstrate cost neutrality, then that is not going to be easy to do at the moment. However, particularly if you're looking at simply the day of surgery costs, I think other than talking to your commissioners or during the conversation with your commissioners, the discussion about reduced downstream costs is definitely worth emphasizing. The way to justify the increased day of surgery costs of robotics is the growing data that there are reduced complications and reduced readmissions, and that's a very powerful downstream cost saving. And I think that is the lever that I would lean on heavily in terms of clinically and financially justifying a move from VATS to robotics. The next question is patients after robotics seem to have less pain and recover faster. How do I explain that? Pain, you have to be careful with pain. My personal view is there isn't a lot of evidence so far of robotic pain being less than VATS pain. Pain after minimally invasive surgery is a difficult thing to study. And we've all seen patients who claim to have terrible pain on day one, but look to be totally fine. And for what it's worth, I think a better metric is ability to comply with physiotherapy, to get moving quickly, to do all of the enhanced recovery stuff that we want them to be doing. I think the objective functional ability to get going on day one and day two is probably far more useful than self-reported pain, which is such a widely varying metric that you need enormous numbers to show benefit. So when we start to study, short-term toxicity of robotics versus VATS, that's what we'll be looking at, measures of physical activity and completing enhanced recovery goals rather than self-reported pain, and obviously also opiate usage to get there. I don't know if there's enough data to say that robotics is better than VATS at the moment. A lot of us would say that anecdotally our robotic patients seem to get going pretty well, but VATS patients get going pretty well as well. There is the potential for less chest wall injury, although there are a greater number of incisions. Those incisions are small, and the way the robotic arms articulate about a fixed remote center means that there is probably less trauma to the intercostal nerves and to the periosteum than there is if you're sticking lots of instruments through a single incision. So I think there is a biological justification to believe that robotic surgery might be less painful. I also think that we know that there's a less cytokine release and less inflammatory response to robotic surgery, and I think it's a much gentler operation in terms of tissue handling. With VATS you tend to grab the lung, with a big grasp and pull it around quite fiercely. Robotics is a gentler operation in terms of overall low-level tissue trauma, and that is reflected in less atrial fibrillation and less of an inflammatory response, and probably also in the patients just feeling less beaten up non-specifically than they would do after a VATS or obviously an open operation. And I think probably that is the biological basis for the patients just looking less haunted and alarmed than they would otherwise do on day 0 and day 1 after surgery. Next question, do you see a major difference in lymph node yield and nodal upstaging? Lymph node harvest is interesting. You can do a complete lymphadenectomy, with one hand tied behind your back if you want to, and there are plenty of reports of case series of people doing extended lymphadenectomies under very difficult technical circumstances. So you can always do a full lymphadenectomy. The question is, will you? And robotics makes lymph node harvesting very different. My standard VATS lymph node harvesting, especially subcarinal nodes, tended to degenerate into pulling out torn handfuls of lymph node bit by bit until I either got bored and demoralized or felt I'd done enough. Robotic lymph node harvesting is very different. You remove perfectly formed little grape-like lymph nodes still within their capsule. You can remove the subcarinal nodal package as one single entity with almost no bleeding right back to the pericardium and the contralateral main bronchus. So it's qualitatively different doing a robotic rather than a VATS lymph node harvesting, unless you're exceptionally patient the way you do your VATS lymph nodes. So it definitely feels like a very different way to do it, and the Guy's data set, which matches some of the international data sets, but we have about 200 case matched robotic versus VATS cases, and we've seen about a 15% increase in nodal upstaging, particularly the critical N0 to N1 upstaging, which obviously changes you from no adjuvant treatment to adjuvant treatment. And that's an initial manifestation of robotics being a better cancer treatment than real-world VATS lobectomy. And we're an experienced VATS center. I'd done 700 or 800 of them, so I felt I was doing an okay job at VATS lymph node dissection. But the fact is, my robotic lymph node dissection is quicker, it's cleaner, and objectively it leads to more nodal upstaging. Let me have a look what other questions we've got here. There's a learning curve question. So a learning curve of VATS versus robotics. It's difficult. I learned VATS lobectomy as a senior registrar in New York. When I had relatively little surgical experience, I learned robotics as a seasoned consultant with approaching a decade of clinical practice. And despite that, it was difficult. I was largely self-taught with robotic lobectomy. It can be a painful process, and I think it's important to be upfront about that. because if you think it's going to be all sunshine and roses, and then you get bogged down in your early cases and are finding it all painful, then you're more likely to give up halfway through your learning curve. So the learning curve, even for an experienced surgeon, is significant. The way to get through it is to have the right support, which doesn't just mean having any proctor, but it means having a proctor who does the operation the way you want to do it and is available, and somebody whom you can have the correct relationship with, because it's an unusual relationship to have to develop as a consultant. So the learning curve is real. As I mentioned, I think probably at a registrar level, it's quicker to learn robotic lobectomy than it is to learn VATS lobectomy, but it's maybe too early to say that definitively. Next question, let's have a look here. Question here, is it mandatory that the assistant can perform a thoracotomy independently? That's an interesting point. I don't think so at all. My emergency protocol is that the console surgeon has to gain almost complete control of whatever bleeding is going on from the console. We always have 2 rolled swabs, which are like big spongy fingers inside the chest, and with 2 graspers, you can either with one or as a pincer movement with your 2 rolled swabs, you can compress the hilum completely, and you can compress the main PA completely if you need to. It's a bad model to have a wild, thoracotomy performed after an emergency undock with free bleeding inside the chest. You will exsanguinate before anybody can get inside, and I've been there. And so, no, my model is for me to, for an emergency vascular injury, is for me to gain immediate control using the robot by pressing. And you have to, it may take you a rather alarming 5 or seconds or so to get control by moving your swabs until you find the perfect place to press, ideally just with one hand. The advantage of the robot is once you're then pressing on this on the bleeding point with one hand, you can then take your head out of the console, and that hand will not move at all. And so you can, rather than if you're pressing and trying to do a thoracotomy, or your assistant's pressing during a VATS lobectomy and somebody's likely to move a little bit during the next few minutes, the robot will very reliably continue to maintain vascular control by pressing on it. And you can then, in a non-emergency, obviously in an urgent way, you've then got a few minutes to scrub yourself, or at least put on a gown and gloves, partially undock the robot and do a posterolateral thoracotomy yourself. So my model, which I think works well, has been tested a number of times by me and my colleagues, is not to have the bedside assistant do an emergency thoracotomy. I think that your bedside assistant will inevitably be somebody who isn't that experienced at doing thoracotomies, and I think it's probably not a good model to have them doing that. It isn't necessary, and you'll probably end up with a thoracotomy in the wrong place half the time. Let me just see if we've got any other questions that have come through. Fine. So I think that is all of the questions that have come through. So I will leave you to go and try and find some breakfast. Thank you very much for joining us today, and good luck to those of you who are planning to embark on the robotic journey in the coming months. It is one of the most rewarding things I've done during my career in the last 10 or 15 years, and I thoroughly recommend it.